Hello everyone. Today we'll be presenting a case of 55-year-old female who was previously operated elsewhere for L4-5 PIBD in 2016. She presented to us with left lower limb radiculopathy with numbness and paresthesia. So we have planned for Para-UBE under GEA. As you can see in the MRI, she is having left-sided disc. So we prepared the patient and planned the surgery under GEA. As you know that patient is put into prone position, and once patient is in prone position, we mark the level and in the standard way and make the incision. Here you can see that we have already marked the incision and started the surgery. Here we have landed on the transverse process of L4-5. As you can see, the bone beneath, this is the transverse process of L4 vertebrae. So I am just coagulating and removing the soft tissue, as there is no muscle involved. This is all fat tissue, and this is the inferior edge of the L4 transverse process. The plan would be to expose the L4 transverse process and the junction with the isthmus and the SAP. So once we do that, then we would be seeing the anatomy and drilling off the lower edge of the transfer process, as you will see in the upcoming video. I am removing the soft tissue from the undersurface of the L4 transverse process. This is a beautiful technique in which, especially in the cases where there is a redo surgery, I use diamond drill in this case, since it is safer to use, and 4 mm bit I use. So once I identify the landmarks, bony landmarks, I start drilling the junction of the transfer process with the isthmus. As you can see, I am just removing the cortical bone, and underneath there is the beautiful medullary bone visible. So you drill off the bone slowly, bit by bit, until you start seeing the edge of the flavum. So as I was saying, that this is the Para-UBE is especially very useful in foraminal discs, or in cases where surgery has already been performed earlier. Since if you go by midline, there would be a lot of adhesions, so which we can totally avoid, because when we are going through transverse transverse process route, so we are not going into the main surgical route which must have been used in the previous surgery in 2016. So here we have drilled off the inferior part of the transfer process of L4, and now I'm trying to gain access under the bony tissue, so that I can chip off the thin edge which is visible here, and gain access to the foraminal ligament and the foraminal ligamentum foramen. So the loose tissue which comes in between, you can coagulate them away using the plasma band. Once you are done with the superior transfer process, then you can turn to the inferior transfer process as well, so that you expose both the transfer processes, and then you get the hold of a torrential bleed under the endoscope. But you need not worry, this can be tackled with easily using your plasma probe or RF probe. Once you are done with the kerosene work, you take a curved curette and try taking the phlegm out so that you create a space beneath. You can easily scrape this soft tissue away and fulgurate it with the RF probe. Now I am dissecting off or exposing the inferior transfer process. As you can see, the bony tissue is visible just beneath the probe, and once you get the bony feeling, you just dissect off the soft tissue, overlying soft tissue, with the help of the plasma probe. Here, the superior surface of the inferior or L5 transport process is visible. And I'm just removing the attached soft tissue from the L5 transport process now. Just keep in mind that you don't have to violate the capsule of the SAP and IAP or the joint. While I am removing the soft tissue, I am not going close to the facetal capsule. Now the TP is almost completely denuded, and both from the superior and the inferior TP. Once you have identified the bony landmarks, so then you start drilling with the diamond drill on the superior surface, supromedial surface of the transfer process. See, this bleeding can be intimidating. You need not worry. You take your scope near to the bleeder and you can simply coagulate it using your RF probe. In the initial days, it can look horrible, it can look non-manageable, but with patience, you can manage it. See, this is bleeding like anything. But once you take your probe closer to the bleeder, it would just settle down. I have deliberately kept a non-edited video here so that you can learn that if there is a bleeding like this, how to tackle it. See, now the bleeding has stopped and the vision has become clearer again. Once you are satisfied that the bleeding has stopped, you can start your work again. Now, since bleeding has stopped, and after the drilling has been done, would just insert a curved curette in the space above the L5 transfer process so as to lift the phlegm. The bleeder has again opened up and it has started bleeding, which is very common. Again, it can be tackled with the same approach using the RF probe, and the bleeding can stop immediately. Sometimes it might take a while before the bleeding stops, but you need to keep the patience and it would ultimately stop. Once you have created a space with the help of curettes, you can take your Garrison forceps and start removing the soft tissue and the ligament from caudal to cranial direction. You need to be very careful while dissecting off the phlegm and the soft tissue so that you do not catch the underlying exiting root. Usually there is a fat pad over the neural elements so you can recognize when you are nearer to the neural elements, the roots or the thecal sac. So as you can see, there is a pad of fat which is visible under the ligament. I am working in the foramen now and taking off the soft tissue which is compressing the nerve root. This step is very important, since if you do not do that, the compression would still remain and patient will not get benefit. Basically, you are doing outside to inside technique. You are outside of the spinal canal and you are going in via the foramen. It's a beautiful technique, since you are able to see everything in crystal clear fashion right in your front, and you are able to use the standard equipments. There's freedom of movement using the UBE technique, and simultaneously you are able to see the things which are not usually visible with the microscope or the other methods of surgery. As you can see now, the nerve root has become visible. Once you see the nerve root, you clear the soft tissues around it so that it becomes free. As you can see, this is the nerve root, this is the exiting nerve root at L4-5 level. It is exiting through the foramen and it is clearly seen here. Once you see the nerve root, you coagulate or fulgurate the soft tissues which are overhanging using your RF plasma probe for a better vision. you try to see the complete path as the nerve root exits from the foramen. While coagulating near the neural elements, you need to be very sure that you have decreased the power of the RF probe to 2 and you are just using the coagulation mode. And once you are near the neural elements, never face the probe towards the neural elements. It should always be the back of the probe which should be towards the neural elements, so that there is no thermal injury to the neural elements. This is the disc which is visible from the axilla of the exiting nerve. I am dissecting off the soft tissue from the axilla of the exiting nerve. We won't be seeing the traversing nerve from this approach, and there is no need to see actually, because that would be more medial and inferior. Once you have identified the exiting nerve root, then you would dissect the inferior edge of the root so as to expose the Kembin's triangle. As you can see, I am using the RF probe. The direction of the RF probe is away from the nerve root. You coagulate the soft tissues from the Kembin's triangle, and then you can cut it using the Kerrison forceps. The nerve root is elevated, it is bulging, and the disc underneath is also, as you can see, it is bulging and compressing the exiting nerve root. You should all be able to appreciate the bulge here from the disc and the compression on the nerve root. This is the disc with a huge bulge. When you are working really close to the neural elements, you can use a point probe. Again, it's a RF probe which is very small and has a very small footprint. So you can use it very near to the neural elements safely. Once you have identified the disc, I usually coagulate and shrink the capsule before incising it. So once I have done that, then I take Indian knife and go inside and incise the annulus. Make a good incision. And there is no need of any retraction whatsoever over the neural elements. So that gives a superior result as compared to the places where we need to retract the elements to expose the disc. Once we have incised, as you can see, we are using the standard disc forceps to evacuate or remove the discs. See, a huge chunk of disc is coming out. Discectomy is then done in the standard way. A lot of disc material is there. I preferably use disc forceps and blunt hook or ball point hook alternatively to remove whatever the fragments are there inside. And once all the loose fragments has been removed, I prefer to use the curettes so that there is no remaining disc inside, which can cause a relapse of the prolapsed disc. Sometimes you need to coagulate the annulus fibers so as to get a better view, and also sometimes when you coagulate the fibers, then it becomes easier for you to remove the remaining disc. There's still a lot of disc present, and that is why there is a bulge or a bend in the nerve root. So I'll try to remove the fragments of the disc so that there is no further compression over the nerve root. You can see there's a huge disc which has come out. A huge fragment, and that was the reason the root was still stretched and bent. Now you can see the bend has gone down as you removed much of the disc part, and the root now look relaxed. Although still a lot of fragments are coming. Oh my god, there's a huge disc again, so still lying inside. See, there's the danger. If you are not vigilant enough, you can actually leave a huge fragment inside. Now the root is completely relaxed after removing this much of disc. So I would look for any other loose fragment inside still coming off. Now, yes. I think now it is almost all the disc has been removed. It is almost empty. Beauty of UBE is that you are able to see it up and close really good in high definition 4K quality, and you can appreciate each and every of the anatomy here. You can go up and close and see for any remaining fragment. That's the beauty of UBE. And in fact, you can do the transcambion fusion as well if you are willing to, or if you want to put in a cage, you can do it from the same corridor. Once all the disc fragment has been removed, I do annuloplasty and shrink the capsule as well as the, if there is any remaining disc fragments, and do coagulation of the bleeders if there are any. So once I am satisfied that the job is done, I take out the scope and close the case. Thank you very much.